Is my title slide visible to everyone?
Yes.
Right. So the brief is to speak on vernal keratoconjunctivitis, and I'm going to present my perspectives on clinical management, and we'll keep it very much practically oriented. So how to diagnose, how to treat, and when to refer. So this is the spectrum of allergic eye disease that we see in our clinics. And I've highlighted in blue the two diseases that tend to be more severe, more chronic, and then that patients tend to come back with on and off. So VKC and AKC are very closely related. The difference being that patients with atopy will also have other manifestations such as skin disorders, asthma, or signs elsewhere in the body. Otherwise, in the eye, practically, they may be indistinguishable, and the management may be equally applicable to both of these disorders. So before starting the actual diagnosis and treatment, it is important to know that what we have been taught over years and decades, and some of the textbooks continue to mention these things, is not always true. So there are a lot of myths regarding vernal keratoconjunctivitis. The number one myth is that it happens in children, usually only in the spring, and it affects people living in hot or tropical climates. It's usually intermittent, innocuous, and not vision threatening. So let me start off by saying that all of these statements are patently untrue. VKC is seen both in children and adults. It can affect patients in any season, in any climate. It occurs all across the world. It can be intermittent, but it can also be chronic. It's not necessary that it is always innocuous. Complications are seen in a certain percentage of patients, and some of these complications can be and are vision threatening also. So it's important to note that VKC is not a mild ocular allergy that we can just brush off. There is a subset of patients who need detailed management over months and years also. For instance, this aspect of VKC is not very commonly discussed, but it tends to be one of the leading causes of an entity called limbal stem cell deficiency, where the ocular surface is very severely affected. So in India, VKC and AKC together constitute about a third of the causes of LSCD, bilateral LSCD. So when a patient walks into the clinic, what makes us diagnose VKC? So there are some signs and symptoms. The signs are to the right and the symptoms are to the left. And these are the common signs and symptoms that taken together would constitute a diagnosis of VKC. The most important symptom is itching. It's very difficult to get a patient of VKC who does not have itching. So if you have redness, watering, foreign body sensation, etc., but the patient does not complain of itching, one might want to look for other diagnoses. Likewise, papillae are usually the foremost manifestation of VKC. So you can have papillae on the tarsal surface, on the bulbar surface. In addition to that, depending on the stage and the chronicity of VKC, one may have other signs. So all these put together, the diagnosis of VKC is not very difficult, just with clinical examination. Does not need any other diagnostic tools. The first step in managing a patient of VKC, in my opinion, is to categorize the disease and to classify it. And there is an excellent paper on this in the IJO, authored by Dr. Nikhil Gokhale. So one classifies this disease based on the severity being mild, moderate, severe, or blinding. And I'll show you examples of these different severity conditions. Also, it is equally important to recognize whether the disease is intermittent or chronic. So mild disease tends to be usually intermittent. Moderate disease can be intermittent, sometimes can be chronic. Severe and blinding forms of VKC usually tend to be chronic. So based on whether your patient has mild, moderate, severe, or blinding disease, and whether it is intermittent or chronic, your treatment strategies would vary widely. So it's very important to remember not to put all the patients with VKC into one box mentally, but to think of this disease as having a very wide spectrum and to recognize in which part of the spectrum your particular patient falls into. Patients with mild disease, as I said, usually have intermittent symptoms, occasionally, sometimes months apart. They may have some itching, some discharge and congestion, but usually they have good visual acuity. The corneal shape, the contour is not affected, and usually there are no other sequelae. So, by that I mean this kind of slight limbal thickening, perilimbal papillae, uh, which is not very severe, and some papillae on the upper tarsal conjunctiva. So, this would constitute mild VKC. What are my recommendations for mild disease? We advise the patient to try not to rub the eye, but just telling that is not going to take away the itching. So you need to give them some medication, some other lifestyle measures. So cold compresses work well. The patient can apply cold compresses on the eyelashes, on the eyelids rather than rubbing the eye. And a mast cell stabilizer or a dual acting agent. My preference is chromoglycate, but you can use whatever you wish. This should be continued for a period of at least a few weeks to months, as these drugs are usually slow acting and they act more for prophylaxis rather than for treating an acute episode. If you notice an acute episode where the surface is very inflamed and the patient has significant symptoms, it is advisable to use a short course of either loteprednol or fluorometholone, which is tapered over 4 to 6 weeks, and this usually takes care of the mild spectrum of disease. If the symptoms are more, so you have more congestion, more discharge, more itching, and the signs are more prominent, then you consider the patient to have moderate disease. One particular sign that indicates that the disease has been present for a longer duration of time is pigmentation on the bulbar surface of the conjunctiva. Sometimes you can even have it in the fornices and also on the tarsal surface in many chronic cases. So that's a giveaway that the disease is not just mild, but it may be long lasting, moderate, or maybe even severe disease. And these are the cases where, in addition to your usual examination, it's very, very important to be aware that these patients can go on to develop corneal ectasia, that's keratoconus. So please check topography. If you don't have topography, at least do your keratometry. If there's something abnormal, then that may be a red flag. Always check the intraocular pressure, because these patients tend to be on steroids over a long period of time. Dilate and check the lens for any opacity, and always keep documenting the status of the optic disc. So what I'm alluding to is that as the spectrum moves towards the severe forms of disease, these patients may have keratoconus, they may have steroid-induced cataracts and glaucoma, and this should not be missed. So you ought to be mentally aware, and every few months, please do your topography, dilated examination, and at every single visit, please check the intraocular pressure. So these are some examples of moderate disease. You can see that the signs are more prominent. The limbal thickening is more prominent. There is discharge. This is what I mean by pigmentation on the conjunctiva, which is a sign of chronic or long-standing disease. Sometimes the pigmentation can also be visible on the tarsal surface. So for treatment, in addition to what we usually do for mild disease, these patients may require slightly stronger steroids in tapering doses, which may include fluorometholone, prednisolone, or equivalent drugs. And that is why it's important to be aware about the potential side effects of these drugs. For all these cases, I always use topical tacrolimus. There are two concentrations available. It's available as an eye ointment, 0.03%, or as 0.1%. The low concentration is usually better tolerated. And the caveat is that as it tends to burn and sting, a very small amount ought to be instilled, either at bedtime or at the most twice daily. So tacrolimus helps in, once you have achieved quiescence with the use of steroids, it helps you reduce the use of steroids and maintain the patient in a quiescent state for a longer period of time. If you have uh, exacerbations of disease on and off, which are quite severe, and you have documented that there was no steroid response in terms of increased IOP with use of topical steroids, one may consider use of supratarsal triamcinolone injections. One specific situation in moderate and more severe forms of disease is formation of a shield ulcer. It is so called because of the shape, and it's usually seen on the upper part of the cornea or slightly paracentral area. And this also needs to be graded, whether it is There's a grading system for shield ulcer depending on whether there are deposits in the base, how chronic it is, and how much is the opacity. So shield ulcers are not a sign of infection. They are usually treated with antibiotics, but antibiotics will tend to worsen the ulceration as this is a form of ocular surface disease. So it needs topical steroids. More severe forms of shield ulceration may need debridement combined with either bandage contact lens application or amniotic membrane application. And in quite a few of these cases, we have to combine these procedures with application of supratarsal steroid injections to achieve control. The most severe and blinding forms of VKC will have all the signs and symptoms that I mentioned before. In addition, they have established complications. So the corneal contour is affected. There may be scarring. There may be pannus on the cornea, which is a sign of limbal stem cell deficiency. Sometimes they may have persistent epithelial defects, a lot of punctate epithelial erosions. And these patients, because they have been treated for a long time, usually also a significant percentage of them may have cataracts and glaucoma. So this is the kind of spectrum of disease that I'm talking about when I say severe or blinding forms of disease. So this patient has had VKC for such a long time that a part of the limbus has been damaged and there is pannus over the cornea. This patient has a very, very severe shield ulcer. There's no infection here. And these are a couple of pictures showing complete conjunctivalization over the cornea, which is total limbal stem cell deficiency and keratoconus. Again, you can have cataracts, you can have optic disc damage, and multiple severe manifestations of this disease. The point I'm trying to make is that VKC is not always mild and innocuous. So if you are a comprehensive ophthalmologist and you're not very well versed with managing the severe forms of disease, the simplest and the best thing to do for these patients is to refer them to an appropriate ocular surface or corneal specialist. Why? The reason is that in addition to all the treatment protocols that I discussed earlier, these patients may need oral steroids. A significant number of them may need systemic immunomodulatory therapy, usually cyclosporin or tacrolimus, and they may need specialized management options such as scleral contact lenses or limbal stem cell transplantation or even keratoprosthesis surgery in very severe forms of disease to restore vision. This is a compilation of questions that we are commonly asked by comprehensive ophthalmologists. And I must emphasize that this is just my opinion and my practice pattern, and practice patterns may vary. But is there a role for lubricants? In my opinion, there is no role for lubricants. Which particular drug do I use? My preference is for chromoglycate as a mast cell stabilizer, but there are other drugs available. I do not use topical cyclosporin because I believe that tacrolimus is cheaper, widely available, and more effective. I'm not very sure that we have good quality evidence on the role of skin tests, immunotherapy, or desensitization therapy, though we would love to have better quality evidence and maybe use it afterwards. About the slightly newer drugs which have been available for the past few years, I don't have any personal experience. And a special situation is keratoconus in VKC. So my advice to practitioners would be to control the VKC first and not rush into cross-linking the cornea because that may create more problems. So to summarize, VKC can be chronic and blinding. I strongly recommend that we learn to categorize it by both severity as well as the periodicity of disease, and do not miss looking for the complications of disease such as cataracts, glaucoma, corneal ectasia, and limbal stem cell deficiency. There are a range of treatment options available, but one should know what is within your own domain to manage. And if you feel that it is going beyond that point, it's always good to refer. Thank you.
Thank you.